to the Unacademy NEET PG YouTube channel. Today is the fourth episode in the series of Images Decoded. For all of those who are new out here, I am Dr. Preeti Sharma, and in this series of Images Decoded, every Tuesday at 8 p.m., I come up with a short lecture of 20 to 30 minutes where we pick up one particular topic of pathology and we discuss only the images of that particular topic. So images are certainly and image-based questions are certainly very scoring in the exam provided you have your concepts set right. And that is our entire motive of behind this particular series. So let me give you a quick recap of what all have we already discussed in this series up till now. So in the previous three sessions or the three episodes that we had, the first two were dedicated to GI pathology where we discussed all the different GIT images, that is esophageal pathology, gastric pathology, and intestinal pathology. Episode number 3, we started with renal path, and this episode today is a continuation to that previous episode. So if in case you have not viewed the previous 3 episodes, the link of the same is attached in the description below. Now let me give you a quick recall of what all did we discuss in the previous renal pathology session. If you guys remember, we started with the very basic of a filtration membrane, and we went on to discuss all the images that you need to know for the nephrotic and the nephritic syndromes. One or two theory questions also associated with the images we had discussed. Where we had ended our session was on nephrosclerosis. I hope everyone remembers the two types of nephrosclerosis, that is benign and malignant. Benign nephrosclerosis shows the classical leather grain appearance of the kidney, and malignant nephrosclerosis shows us the flea-bitten appearance of the kidney. So that is the last topic that we did in the previous session, and let me tell you, today we have a lot of interesting topics coming up like systemic disorders, that is including diabetes and SLE. Then we'll be going on to a disorder called chronic pyelonephritis, which gets you questions. Also, we would be discussing the renal tumors, be it benign, malignant, adult, childhood. And in the end, for all the second year MBBS students out here, something that is surely going to help you in your practical examination, as well as the students appearing for their MCQs, guys, urine examination. So all the important images and procedures that you need to know are also put up in this session. So without wasting any further time, like I say, let's fall in love with renal pathology and let's proceed with the intricate details and the important image-based questions that you have to know. Like I told you, the very first group of disorders that we will be starting with would be the systemic diseases, which will include diabetes mellitus and SLE. I'm sure everyone is well versed with the theory out here, so I'll straight away go on to the image part of it, and that is the motive of this session. The very first picture that we have, we are talking about diabetic nephropathy, so diabetic changes in the kidney. And the very first picture, guys, that I have for all of you over here is the very first change that is taking place. So I hope all of you can appreciate most of the pictures I've highlighted and labeled so that you get a better overview of it. So you can appreciate this round structure over here is a glomerulus, and if you strain your eyes and note carefully, you will be able to see that the capillary loops are thickened. Guys, that is the very first change that we have. There is thickening of the capillary wall. Let's see further. A feature which all the students really like. Again, I've got a glomerulus over here, but something has changed in the glomerulus, right? So first and foremost, what is the name? It is a KW lesion, the Kimmelstein-Wilson lesion. And you know, that's a fancy name, but let me tell you a more practical name of it, which helps you identify this picture. And the practical name is nodular glomerulosclerosis. Break every part of it. See, go in the opposite direction. Let's start off from sclerosis. So what do you mean by sclerosis? First and foremost, all the pinkish material that you see deposited in this entire glomerulus, all the pinkish material that you're seeing deposited, sclerosis appears pink on microscopy. Okay, on a regular H&E stain, sclerosis appears pink. Can I say pink refers to eosinophilic? So that is what it is. Sclerosis is pink, where in the glomerulus, so glomerulosclerosis. And what is the first word? Nodular. So do you appreciate it appears as if this glomerulus has been divided into different nodules. So nodular glomerulosclerosis. That is the most characteristic lesion that you see in a case of diabetes mellitus in the kidney, and that is given a fancy name, that is the KW lesion. Okay, the next two, watch out guys, you need to be very attentive for the next two lesions. The next one is something known as a fibrin cap, and I've got it labeled for you so that you do not have any confusion. You know, on the capillary loops like a cap, if you notice these two arrows that I've drawn for you, On the capillary loops, sitting like a cap, that is what is referred to as a fibrin cap. So see over here, now to show you two pictures, you need to know their differences. If it is sitting on the capillary like a loop, I call it a fibrin cap because it's like a cap, okay? On the other hand, if the same thing, it appears as if it is dropping from the capsule. Now look at this particular arrow over here. Look at this pinkish deposit which appears attached to the Bowman's capsule, right? So this outer lining everyone knows is the Bowman's capsule, and this thing that I've marked with an arrow, it is a pinkish deposit which seems to be attached to the Bowman's capsule. What do I call it? Capsular drops. Another lesion, which is a branded name, is the Armani Epstein lesion. You know, you don't get a picture for this, but for your completion, I've got it up out here. What is Armani Epstein lesion? You know, all these changes that I told you up till now, did you notice all of them are happening in the glomerulus? Now I've got to change a branded name which happens in the PCT, the proximal convoluted tubule. And what is that? What is getting deposited? It is glycogen that is getting deposited. Guys, quickly let me know in the comment section. You guys know that there's a live chat box available. What is the special stain for glycogen? Anywhere in the body you see glycogen deposition. What is the special stain that all of you will apply? For glycogen, it is always PAS stain. Yes, periodic acid shift. So the PAS stain is very important for glycogen. And guys, do you remember our basic mnemonic, general path? P for pass and P for pink. Yes. So if someone asks you what color does pass give to glycogen? So pass always, no matter what it stains, pass always gives a magenta pink color. So to complete your theory out here, although I always say that this is an image based session, but I can never stop myself from discussing one or two questions which are important for your exam. This is one of them. When they say papillary necrosis or death of the renal papilla, you have a mnemonic, a very nice fancy mnemonic that we have which helps you remember the different causes. Now, suit yourself. You can remember it as soda, you can remember it as dosa, whatever you prefer as per your liking. And what is the full form standing for? S for sickle cell anemia, O for obstruction, D for the disease that we are studying right now, that is diabetes, and A for analgesic overuse. So sickle cell, obstruction, diabetes, analgesic. That is what causes papillary necrosis. So I hope everyone's clear with the diabetic changes that we get in the kidney. Quickly guys, let's now do the other systemic disorder. What was the other one? I hope everyone remembers SLE or lupus nephritis. Now again, a quick question to you that you need to answer. I hope everyone remembers from your theory that there are certain classes of lupus nephritis. So quickly tell me, how many classes do we have? How many classes do we have of lupus nephritis? Ranging from class 1 to class 6. There are 6 classes of lupus nephritis, out of which something that you see, the characteristic lesion which I've written out here, the wire loop lesion. Guys, let me tell you, when I say that SLE has class 1 to class 6, wire loop lesions are maximally seen in class number 3, 4 and 5. Okay, 3, 4 and 5. However, which is the class out of these where it is maximally seen? Out of class 3, 4 and 5, where do you maximally see this wire loop lesion? Guys, how many alphabets does wire have? 4. How many alphabets does loop have? 4. So this is maximally seen in class 4 lupus nephritis. What do you understand by a wire loop? Something that is stiff, you would be able to appreciate it like a loop-like structure. So if you appreciate all the capillary loops out here, do you notice that periphery, the loop, the turning point, the loop of it appears a little more pinkish or appears a little more thickened? Why? Because this is the wire loop lesion that I'm talking about, that you see in a case of lupus nephritis. Now, there are two types of questions, and especially I'm targeting this, guys, for you for the AIMS paper, where you started getting a lot of true and false type of questions, right? So if they say full house effect is seen in SLE, is it true or false? Everyone answers it now. It is a true statement. If they say full house effect on immunofluorescence is seen only in lupus nephritis or only with SLE, no guys, till a long time it was thought that full house effect is something which is very specific to SLE. But no, a lot of studies have been published, and in the top most kidney or renal pathology journals that I'm giving you a reference from, it is said that this is highly indicative of lupus nephritis, but it is not specific. You have to look at the whole picture, the patient profile, the biopsy, the immunofluorescence as a total with all the criteria, and not rely only on the full house effect. You cannot say that it is specific only for SLE. Full house would mean all the main things are getting deposited. Okay, so what are the main immunoglobulins? IgG, A, and M. Okay, and the main complement proteins like C1q, C3, and C4. Okay, so IgG, A, and M, C1q, C3, C4. So all the main immunoglobulins, all the main complement proteins are getting deposited. So this is a full house effect. So I hope everyone is clear with these two, that is diabetes as well as SLE or lupus nephritis. Now moving away from the systemic diseases, let's talk about a disorder which involves the tubule. It's a tubular disease. Previous class and this class, we have only up till now spoken about all the glomerular disorders. We have kind of ignored the tubular disorders, and this is one of them that I want to show you. So CPN is how you call it, chronic pyelonephritis, and precisely there are 2 points about it that you have to know, your take home message I would call it. So what is CPN if you break the term chronic? So chronic, it is a chronic infection. Pyelonephritis, itis again means inflammation. So it's going to be a disorder where I'll see a lot of chronic inflammation, right? Firstly, when you look at the kidney grossly, guys, we see an irregularly scarred kidney. Okay, we see the presence of, you can see these cortical scars that are present. We see an irregularly scarred kidney, number one. But what gets your attention in the exam is the microscopic finding. And I'm going to show you a microscopic finding and then tell you four very characteristic features. So that's a beautiful pink and blue slide behind us over here. Now in this, many a times examiner is going to obviously give it to you in this power, but while learning, you must zoom into every area and you should be able to identify the areas. So let me do that for you. When I say chronic pyelonephritis, I told you it's a tubular disorder, right? So you should expect all the changes in the tubules. But they will ask you, is there any glomerular disease also? Is there any glomerular problem that can occur? So then, yes, it can. Look at the very first problem out here, guys. I've highlighted and zoomed into only one, but you can certainly talk about the others. This is something known as periglomerular fibrosis. So I told you it's an entirely tubular disorder. Glomerulus is not affected. And in the top corners, you can see that the glomeruli are pretty much normal. But look at this particular glomeruli that I have zoomed in for you. Do you see around the glomerulus, there is a kind of fibrosis that has taken place, right? So please remember, similarly, you can see in the other glomeruli also over here, you can see that around the glomerulus, there is a fibrosis present. So number one, periglomerular fibrosis. Next part that I want you guys to zoom into. So I've got a good high power for you because this is the mainstay. Guys, all of these structures are the tubules. All these round structures are the tubules. Do you see any lining to them? You don't. So can I say the tubular lining has been atrophied? They're just round structures. I don't see any cells lining them. So can I say the lining has been atrophied? Number one, atrophic lining of the tubules. And then, aren't all of them filled with pinkish material? Does this remind you of any other organ? Remember, thyroid gland. Thyroid gland also has these round structures which we call as follicles. And what are they filled with? They are filled with pink material, just like this. What is the pink material in the thyroid? You call it colloid, right? So can I say somewhat the kidney has started looking like the thyroid gland? What do I call it? Thyroidization of tubules. Thyroidization of the tubules. So guys, please keep this in mind. Number one, the lining is becoming atrophied. Number two, there is thyroidization of the tubules. The last point, the last point that I'm going to show you is the very first point that I highlighted. Look at these three yellow arrows that I've got for you. Did not I say in the beginning that this is chronic pyelonephritis? It's a chronic inflammation. So all the yellow arrows that you see out here, they are those blue color dots. Do you see this entire picture? So I can't point at any one area, but this entire picture has a lot of these blue color cells in between, scattered in between. That's the chronic inflammation. Guys, that's the lymphocytes. So quickly, let's do a quick recap of the four features that I told you in CPN. Number one, I told you there will be presence of periglomerular fibrosis. That's the only glomerular change that occurs. Next, I told you the lining of the tubules would be atrophied and it will be filled with pinkish material. So you call that the thyroidization of tubules. Next, I told you that in between you will see scattered blue color cells, which are the lymphocytes, which basically indicate the chronic inflammation. So that is why this disease in a total is referred to as chronic pyelonephritis. Guys, a quick question to you. anything that you will see in the urine examination of a case of chronic pyelonephritis. Any, one very characteristic thing. Let me ask you, in another direct manner if you can't answer. So I hope all of you are aware. Please answer in the live chat box. In a case of chronic pyelonephritis, in the urine we see something known as a cast. Which type of cast? It's an infection, so we see a WBC cast. Don't worry if you don't know about it, because today's session will also show you the casts and the crystals. So you will see a picture of that as well. But for the time being, we've discussed the systemic disorders and we have finished with chronic pyelonephritis. The next group of images that we have is a very short topic. All of you have heard of it and the picture pretty much speaks for itself. That is the polycystic kidney disease, PKD. Guys, do you remember from your theory that there are two types, autosomal dominant that you see in adults and autosomal recessive that you see in children? So these are the two pictures that you get in the exam, and it's the outer surface of the kidney which speaks volumes about it. When I say autosomal dominant polycystic kidney disease, first picture that I've got is, the outer surface of the kidney. The second picture that I've got out here is the cut surface of the kidney. Do you see that I'm seeing cysts on the outer surface also, and I'm seeing cysts on the cut surface also? That is a very important finding that you see in autosomal dominant polycystic kidney disease. Outer also and inner also. But when I'm talking about autosomal recessive polycystic kidney disease, let me tell you, the outer surface does not show cysts. Now that's the point which helps you differentiate. The outer surface appears normal. The surface does not show cysts, but look at the inner surface. Now the inner surface will show you these radially arranged cysts. Okay, it will show you very small. You need to kind of strain your eyes a little bit, I'm sure, but it is appreciable. You can see these radially arranged cysts that are present. So quick revision, autosomal dominant is going to show you cysts on the outer surface as well as on the cut surface, whereas autosomal recessive is going to show you cysts only on the inner surface which are radially arranged and not on the outer surface. So guys, this is particularly oriented for the second year MBBS students who have a problem with the urine examination. So in this, I'll be telling you all the biochemical tests as well as the instruments that you get in your instrument tray. Obviously, this is not a theory session, so I won't be discussing the procedures and the principles. I'll just be telling you the images that you have to know. So even for the MCQ aspirants, it is very important. We'll divide it into biochemical tests and microscopic findings. Under biochemical tests, we'll test for protein, sugar, bile salt, bile pigment, the ketone bodies, the specific gravity, the albumin, and under microscopy, we'll talk about casts and crystals. So beginning first with the biochemical tests, and the number one, I'm sure everyone has seen this picture and already identified it. I've got a test tube in which there's a blue color solution and I'm heating it. So on heating, this might change a color. I'm sure everyone's got it. I'm talking about the Benedict's test. And that is something we use for detecting the sugars. And you know how do we grade it? That's on the basis of the color changes that you get. So you're going to take Benedict's in a test tube, you're going to add urine to it, you're going to heat it up, and then you're going to see the color change. So the color obviously changes from green, yellow, orange, and brick red. And I'm sure all of you remember one step beyond brick red also, that is brick red with a precipitate. So that is how the different gradings are done. And obviously, I'm not talking about the theoretical part of it. That's an altogether different session. So we should be able to identify. But a very important Viva question is that this particular test which you do, the Benedict's test for sugars, you are going to heat the lower part of the test tube. Because which is that test where you heat the upper part of the test tube? So you've got a test tube out here, as all of you can appreciate, and you've got urine inside it. Now, to this test tube, look at the area that I'm heating. I am heating the upper part. So I've filled 3/4 of the test tube with urine and I'm heating the upper part. Why? Because if there is protein present, the lower part serves as a control, and the upper part, if there is protein present, all of us know protein coagulates on heating, right? That's the principle. Protein coagulates on heating, and that is why, what do you call it? You call it the heat coagulation test, and that's the picture that you have to know for it out here. The next one, and I think everyone knows this test as soon as you see this classical ring formation out here. It's the Rothera's sodium nitroprusside test, right? Sodium nitroprusside is the agent that is used, which gives you a classical violet or a purple color ring that you see out here if ketone bodies are present. So that's the Rothera's test for the ketone bodies. The next one that we've got is for two tests, one for bile salt and one for bile pigment. So what is for bile salt? For bile salt, we have something called the Hayes sulfur test. Obviously, which chemical are we using out here? We are using the, yes, sulfur of course. So what do we have? Over here I put up two test tubes for you. The first one that you see is the control, is a normal urine. So you've sprinkled the sulfur, and this normal urine, I mean to say, does not have the bile salt. So do you see the sulfur is present on the upper part? It is floating on the upper part. But in the next one, when you see a positive test, when you see bile salt present in the urine, do you see the sulfur has gone down and deposited at the bottom of the test tube? Why? Because bile salt lowers the surface tension of urine. It lowers the surface tension. So the sulfur that you sprinkled has come all the way down to bottom. That is the Hayes sulfur test. The next one that you have, the word itself tells you the name of the reagent that also you're using. It is for bile pigment, and the name of the reagent is the Fauchett's reagent. So the name of the test is the Fauchett's test. Not going into the details of the procedure as of now, that's a theoretical topic, but the color is what you need to know, that when do you call bile pigment positive. So please remember, you always add the Fauchett's reagent on a filter paper on which you've taken a precipitate. So when you add the Fauchett's reagent, you get this characteristic blue-green precipitate, okay? And that is what is the positivity for bile pigment. So remember, for bile salt, the positivity was with Hayes sulfur test when the sulfur sinks to the bottom. For bile pigment, the positivity is with this blue-green precipitate that you see on a filter paper. The reagent is the Fauchett's reagent. Two more tests which you need to know, which require two special instruments. And guys, all the second year MBBS students, this is coming in your instrument tray. This one is known as the SBAC's albuminometer. The word tells you everything about it. It is used for measuring albumin. So do you notice it has two markings? The U marking is where you fill the urine till, and the R marking is where you fill the reagent. And what is the reagent? What is the name? It's SBAC's albuminometer. So what is the reagent? SBAC's reagent. It is a mixture of picric acid and citric acid. It is said that under an acidic environment, that's the principle, just one line about it. Under an acidic environment, the protein or the albumin will coagulate. So you've added picric acid and citric acid. So the albumin will combine with the picric acid, right? And you've also added citric acid, so that has created an acidic environment. So the albumin will combine with picric acid to form albuminopicrate, and that will precipitate and that will settle down, that will precipitate. That is what you will measure with the help of these markings. So what is SBAC's albuminometer? It's a tube having a U marking for the urine, the R marking for the reagent. What does the reagent contain? Picric acid and citric acid. What does it help you in measuring? The amount of albumin. The next and the last one that you have to know, guys, is something known as the one that you use for measuring the specific gravity, okay? And that is a urinometer. So I've shown you two pictures. One I've shown you the different parts, and the other I've shown you how it is done. So do you notice there's one empty test tube, and then there is this structure out here that you see. What is it? If you notice, it has a stem, a very thin stem, and in the bottom it has something called as a float and a steel ball kind of a thing that is present. So what do they do in this particular test that you see? So in this test, they fill that empty test tube with urine, and then they drop this inside that urine. They don't just drop it vertically, they spin it and drop it. This is a kind of a test which depends on the buoyancy, something we used to study in our 10th 11th grade. This is to do with buoyancy, and obviously that depends on the specific gravity, correct? So you just spin this particular structure that you have over here, the stem and the float. You spin it around, and that is how you drop it inside the test tube. You just don't throw it vertically. You would spin it and throw it down, and then you see how much does it rise. So that is how you measure the specific gravity, and the name of this particular instrument is the urinometer. If you want to know all of these in detail, I will be discussing them on the Unacademy Plus platform in the lectures that will be coming up on kidney pathology. So I will have a separate session for the urine examination also, and I'm sure all of you should attend that, because it will help you, especially the second year students, to get your principles and procedures clear for your YY exam. Okay guys, so all of this was to do with the biochemical and the physical properties. Now let's talk about the microscopic findings, right? Under the microscopic findings, we will have crystals and casts. Now guys, having discussed the biochemical tests that you have for urine examination, now let's proceed with our discussion of the microscopic examination. Now, there are a lot of tests that are done when we are dealing with the microscopy, but pertinent to the images part of it, we have two things, that is the crystals and the cast. So let's begin with the crystals, and the very first one that we have is referred to as the calcium oxalate crystal. It has two shapes and two forms. As you can appreciate over here, there is one very pretty envelope shaped crystal, right? So that's the envelope shaped crystal that we've got. That is calcium oxalate dihydrate. And at the other corner, we've got a dumbbell shaped crystal, and that is calcium oxalate monohydrate. So firstly, calcium oxalate crystals are of two shapes. One are the envelope shaped and the other is the dumbbell shaped. How do you remember their forms? Simple mnemonic. D is not for D. So remember, calcium oxalate dihydrate is not the dumbbell shaped. It's not the dumbbell shaped. D is not for D. Dihydrate is the envelope shaped. Monohydrate is the dumbbell shaped. Moving on, the next one, in cases of gout or in cases of hyperuricemia, you see these classical rhomboid shaped crystals, which are the uric acid crystals. Next appear hexagonal plates, not a very common finding, but whenever the cysteine levels are elevated, increase in cysteine, so cysteine crystals appear hexagonal. The fourth one is a favorite with the examiners, which there are three fancy names that I'm going to give you out here. First and foremost, what is this shape? So this is known as the coffin lid shape, okay? Coffin lid shape. If they ask you what crystals are these, so the fancy name for that, they are the struvite crystals. But if they ask you the composition, it is triple phosphate. So when you see this picture, guys, there are three words that have to come to your mind. Number one, it's a coffin lid shape. The fancy name for this is the struvite crystal, and the composition is triple phosphate. The next one looks like a bunch of needles, right? So lots of needles which have been put together like a bunch, correct? So that is the tyrosine crystals. Again, something that has not been tested too much in the exam, but trust me, you can get it. So when you see this bunch of needles over here, then you see a bunch of needles out here, so which has been put together, that is the tyrosine crystal. Another one coming your way, the last one, is known as the ammonium biurate crystal. How does this appear? The ammonium biurate crystals are said to have the classical thorn apple appearance, okay, the thorn apple appearance, and you can very clearly see that over here. And I've also put up a thorn apple so that a visual memory always helps you recall better in the exam. So the ammonium biurate crystals are the thorn apple appearance. But before I go on to the casts, there's one, collateral image-based question that I want all of you to solve over here. Didn't I tell you a while ago that there is something called the struvite crystal or the triple phosphate crystal, correct? Now that's a crystal. Quickly tell me, quick recap, what shape was it showing me? The struvite crystal or the triple phosphate crystal, what shape was it showing me? Yes, the coffin lid appearance. Now those were crystals. If the same thing ends up forming a stone or a calculus, guys, I hope all of you remember the same composition. You call it a struvite stone or you call it a triple phosphate stone. Remember? That is exactly what I want to show you over here. This is a classical surgery question. It is a triple phosphate stone or a struvite stone which has the shape of a stag horn. Let me zoom in for you. It has the shape of a stag horn. So the horns of a stag, okay? So that is why you call it the stag horn calculus. Look at it without the zoomed in view. So this is how you will get in the exam. And look at this stone. It has a stag horn appearance. So please remember, this is the triple phosphate stone. Now, what have we called it? We've called it stag horn, and I told you it basically looks like the horns of a stag. So they will ask you, what are the other things in pathology which have the same stag horn pattern? So guys, there are three things in pathology which have a stag horn appearance. Number one, you've already seen. That is the stag horn calculus. The next one, and if you know the answer, please comment in the live chat box. There are two more things which show a stag horn appearance. That is a vascular tumor by the name of hemangiopericytoma. So now, whenever we see a vascular tumor, the blood vessels are nice and round. But when I see a vascular tumor over here, do you notice these vascular lumen, these spaces, they are again, they are irregular, like the horns of a stag that I was showing you right now, like the horns of a stag that we just saw over here, right? So can I say hemangiopericytoma shows me the presence of stag horn blood vessels. And what's the other thing? The other thing is fibroadenoma. Guys, everyone knows that for breast lesions, we do a technique called FNAC, right? Fine needle aspiration cytology. So how does an FNAC slide of fibroadenoma look like? Again, the clusters have this stag horn appearance. So three things for stag horn. Number one, stag horn calculus. Number two, hemangiopericytoma. And number three, the FNAC finding of a fibroadenoma. Moving on to the next one, that is, all of this was just a collateral question, but what we were discussing were the crystals. And next what we need to discuss are the casts. So the very first that I've got over here is a very, it looks transparent. This is the hyaline cast. So it's a cylindrical transparent structure that you see. There are two that you see in this field. I've highlighted this one for you. It's a cylindrical structure, transparent, known as hyaline cast. This can be seen, one can be seen normally also in a normal person. But following strenuous exercise, in pregnancy, following high grade fever, this can be seen in the urine. But do you notice there's no any major pathology why we are seeing it? All physiological causes like pregnancy or exercise, and even normally. So what is it? If you are seeing it normally, what exactly is this? This is basically a protein which is being released by the loop of Henle. What is the name of that protein? That's a previous year question. It's the tam horsefall protein. So remember, tam horsefall protein secreted by the loop of Henle comes out in the form of these cylindrical structures called the hyaline cast. This was normal. Something sticks on top of it. Look at the next picture. What do you see out here? Now it's no longer that transparent structure. Something is sticking on top of it. And what is it? Those are the red blood cells. So what do you now call it? We call it a RBC cast, a red blood cell cast, because all the red blood cells are filling it. And where do you see an RBC cast? In a glomerulonephritis. The glomerulonephritis shows you RBC cast. Now instead of an RBC, if WBCs are stuck on this, like you see very nicely over here, and I just told you the disease also. So in this entire cylindrical structure that you have out here, it is studded with these white blood cells. Guys, where do you see a WBC cast? Did we not discuss something called CPN right now? Chronic pyelonephritis. So WBC cast is seen in chronic pyelonephritis. The next one, now this cast suddenly looks very, very broad, right? All of those were a little slender. This now looks extremely broad. So this is a broad waxy cast, also known as the renal failure cast, because this type of a cast you see in chronic renal failure. The last one that we've got, it looks very dirty. It looks very brown. It's the same cylindrical structure, but it looks extremely brown, muddy brown, right? So this muddy brown cast is seen when there is a lot of death taking place in the tubules. So what have I called it? Because it looks muddy brown, I call it a muddy brown cast. Why? What is dying? Look at the name of the disease. ATN, acute tubular necrosis. The tubules are dying. So all those dead cells are coming out like this dirty material, okay? So muddy brown cast is seen in acute tubular necrosis. So guys, this was what you had to know for the biochemical as well as the microscopic findings of urine examination. Particularly the microscopic findings for the exam, that is the casts and the crystals. So guys, coming to the very last part of renal pathology, and that is renal tumors. Now how are we going to talk about renal tumors? First we'll talk about all the adult renal tumors, and obviously we'll only stick to our images for this. And in this we'll talk about two disorders. One is something called AML, angiomyolipoma, and the other is the classical renal cell carcinoma. Then we'll go on to the pediatric lesion or the pediatric tumor for kidney pathology, that is the Wilms tumor. So the very first picture that I told all of you, that is of a case of angiomyolipoma of the kidney, AML. Quickly let me know within a few seconds which particular syndrome is this associated with. Angiomyolipoma of the kidney is associated with which syndrome? Do let me know in the comment section. I hope all of you got that. It is tuberous sclerosis. Correct. Okay, so what is the word angiomyolipoma telling you? Let's split it. Angio. So I'm going to zoom in three portions for you over here. The word angio would obviously refer to the blood vessels. So very clearly on the top, do you see that there are these thickened blood vessels present? So angio. What is the next word? Myo. So do you see these spindle shaped, this entire rectangular structure that I've highlighted? These are all the spindle shaped myoid cells. So angio sorted, myo sorted, and the topmost over there. The topmost that you see in that particular area is the lipo, the fatty part, okay? The one that is clear. So number one, you've got the angio, next you've got the myo, and top corner you've got the lipo. So look at this without the labelings also, because that is how you will get it in the exam. This is how this tumor appears, which is angiomyolipoma of the kidney that you see in a case of tuberous sclerosis. Now, as the word suggests, it's a benign tumor. But talking about the malignancy, that is renal cell carcinoma, the most common variant that we have is the one that is shown over here. Very classically, I don't need to point out on any one, but I've still highlighted it on a higher power for you. You can see all the cells are clear. They are completely clear. If you study your theory, you'll get to know that they are clear because they are filled with two things. Number one, glycogen, and number two, fat. They contain glycogen and fat, and that is why all of them are clear. Look at it without the labeling. So look at this full field has clear cells. So what would you want to call this? You will call this the clear cell RCC. Guys, this is the most common variant that you see of renal cell carcinoma. The next picture that we've got is where this renal cell carcinoma now starts having papillary projections. Let me highlight one for you. So do you notice this big, finger-like projection, a papilla that is present over here? So are the cells clear? No, they are not. So this is not clear cell RCC. The cells are showing a papillary configuration. This is papillary RCC. I hope all of you remember 2 points from your theory. This is very commonly seen in dialysis patients. And number two, any papillary carcinoma of the body shows which type of calcification. Guys, remember every papillary carcinoma shows us the presence of samoma bodies. Yes. So be it papillary carcinoma thyroid or endometrium or ovary or the kidney for that matter. So this bluish round structure that you see over here, this is the samoma body which you see in papillary RCC. The third and the last one, and I've given you a very nice hint. This is a tumor where you see something called the plant cell. What is the plant cell? Let me highlight it for you. What do you see in this highlighted version? Do you notice the outline of the cell is very, very demarcated and clear, very sharp outline. And there's a little bit of perinuclear clearing. Around the nucleus you see a whitish zone. So there's a very sharp boundary and there's a perinuclear clearing. This is the plant cell. Which tumor am I talking about? Chromophobe RCC. I hope everyone remembers the one with the best prognosis. The last question coming up your way in RCC, what is the special stain for chromophobe RCC? It is Hales colloidal iron. That's the bluish picture that you've got. So please remember, when it comes to chromophobe RCC, you have to remember two images. One is of the plant cells that I showed you right now with the perinuclear clearing. And number two is of the Hales colloidal iron, which is giving you this bluish appearance. Guys, these were about the adult tumor, that is renal cell carcinoma. Now I'm going to show you a picture which is of a childhood tumor. Everyone knows I'm talking about Wilms tumor. What's the other name of Wilms tumor? It is a triphasic tumor. Remember, it has three things. Let's zoom in. This picture has three things inside it. Let's zoom into it. Number one, do you notice I can see tubules? I can see these round structures out here. These are the tubules. So can I say number one component is the epithelial component? Next part that I see over here, I see spindly cells. So that is the mesenchymal component. The mesenchymal component. So number one, the epithelial component. Number two, the mesenchymal component. And number three, do you notice the rest of the slide is very, very blue in appearance? So what is that bluish thing that I've highlighted right at the extreme corner in the end? That's the blastomal component. So guys, see it without the labeling also. This is how the picture will come to you. It is going to show you three parts to it. That is the epithelial, the mesenchymal and the blastomal. Because it has three parts, that is why I refer to it as the triphasic tumor or the Wilms tumor. So guys, this is what you had to know when it comes to the images of kidney tumors, the adult as well as the pediatric. So I hope all of you have benefited from this as well as the previous session of renal pathology, because this was a cumulative summary of all the images that you have to know in this, and that is what the series is all about, that is images decoded. So that is all from me for today, and I hope all these two sessions have helped you fall in love with it, and this subject or this particular topic is not as dreaded as it was earlier for many students. So guys, we will be meeting again next week, same time, same day, that is Tuesday 8 p.m. with another chapter. And if you have any particular chapter, then please do let me know today itself in the comment section so that we can prepare accordingly for the next week. So obviously this session, I wanted to be an interactive session and I wanted to be on the basis of the student feedback so that you guys should be benefited maximally before your exams. So if you have any particular chapter, I'll go by the poll and I'll go by the majority votes. So if you guys have any particular chapter which you want should be discussed earlier, so let me know and we can start off with that for next Tuesday. So till then, I'm signing off, and all of you please stay safe in this particular time, in this lockdown, and keep studying. Do not get demotivated. Make use of this time. Utilize it properly. Make a timetable. Sit down and study. Attend all the lectures that we are providing to you and make adequate notes. I always say make your own notes, make your own handwritten notes. Do not rely on others, because that is what will really help you in the end. So guys, see you again next Tuesday at 8 p.m. with another session of Images Decoded.